Dr. Harris.
Thank you very much, Mr. Chairman, and thank you, Dr. Homburg, for coming before the committee. Just some brief questions on a variety of topics. There was actually an article on CNN this morning about the Olympus scope. You know, I understand we're changed in the elevator channel. You know, they probably thought they were doing something good. It turned out it was something bad. I think prospectively probably no reason to know that, but we do know that now. What changes, if any, would this this case, what changes should it make to our device approval process? I mean, I think pretty clearly Olympus felt this was an improvement. It turned out to be detrimental. Is there a way we can change the process? Briefly, if you could.
Yeah, I'll try to be brief. This is a complex topic, and we'd be happy to come and give you a full briefing. I think it's important to first frame it that duodenoscopes are very important medical devices addressing serious problems and lowering risk for patients overall by doing the endoscopic approach as opposed to open surgery. And there are about 500,000 of these done a year, to benefit patients. In the case of these duodenoscopes, though, and the very nature of what the task they're trying to do in ERCP and getting into the biliary tract, the design has this intrinsic complexity of the elevator mechanism. The issue you're talking about that was in CNN today, I think, is not a clear-cut issue. There are 3 products that are in the marketplace now. Olympus has the majority of the market share, but all of them had been approved through the 510K process originally. 2 of the products had a closed channel. Right. Olympus's 510K was originally with an open channel, and they began to manufacture with a closed channel. I think, reflecting the sense that might help. Might actually help.
So I mean, do you think we need to change the approval process?
Well, what's complicated here is they were trying. They thought they were coming into alignment with the other products in the marketplace that were closed. They didn't realize that it was a substantial modification from the FDA perspective that would require them coming to us for a 510K. As soon as we learned about this problem, we told them that they did need to apply. They initially disagreed.
Thanks, and I don't have time for you to get into any more, but I've got a variety of questions. The next 2 or 3 really deal with some scientific evidence. One is on partially hydrogenated oils. My understanding is that the FDA has announced a tentative determination to ban all partially hydrogenated oils, and you're going to come out. And my understanding is that there may be something coming out that would give only a year for a transition to eliminating all partially hydrogenated oils. But the scientific evidence is that below a level of 2 grams a day, there doesn't, or I'm sorry, 2% total energy a day, which is 4 to 5 grams per day. There's not any. I mean, the evidence is not good that you're achieving anything. That in fact, like a lot of things, if you take a whole lot, it's bad for you, but a little bit isn't bad for you at all. So, there are industries like the baking industry that uses partially hydrogenated oils, which would be severely handicapped by a 1-year process and I don't bake. But my understanding is that the oils you use are very important, and then changing over to new oil is not easy. Why just simple question? Why just 1 year? I mean, we've lived with partially hydrogenated oils. We've decreased the consumption by 75% over the past 10 years. Why rush to this? Why not give a couple years transition, 2-3-year transition?
Well, partially answering Congressman Yoder's question also about the analyses we do, we have been working closely with the industry and hearing their concerns about product reformulation and access and use of other oil substitutes, et cetera. We are not locked into a phase-in period. We think, based on the available science, that decreasing partially hydrogenated oils to as close to 0 in the diet as we can get and using other oils instead would be extremely beneficial.
Well, I'd appreciate you just to show me the studies that show that decreasing it to near 0 is a substantial decrease in risk from, as I said, the 2% energy or 4 to 5 grams a day. Finally, in terms of salt, intriguing article last year, New England Journal of Medicine, from the Pure study. Look, I grew up learning in medical school, yeah, salt is bad, and tell everybody eat a little less salt. Yet that study actually indicates that if you are a healthy person, you actually have an increased cardiovascular risk of salt restriction. That's not clear. I mean, I think, you know, the party line is that salt is bad and decreasing salt is good, but it appears that's not really true. I mean, is the FDA thinking about working the dietary guidelines to admit there's actually real uncertainty about which category of patients benefit and which actually may be harmed by limiting sodium intake?
Well, I think that there is a very large body of evidence and literature that supports the value of reductions in sodium from the average intake of Americans today. There have been some studies that have raised questions, and it is very hard to realistically do some of the studies that might definitively show you know, the one-to-one causation, because these are, you know, cardiovascular risk and risk of stroke is very multi-determined. But we do know a couple of things, that most of the sodium that people take in is from processed food, not from the salt shakers, and that if we're going to make a difference, we do need to look at that source of sodium. And we do know, as I said, that there is a very, you know, large body of literature that shows that reducing sodium has significant, meaningful impacts on hypertension and other risks. So I think that, you know, we are deeply involved in examining the science. I mentioned our new center director for the Center for Food Safety and Applied Nutrition. She's already deep into these issues and reviewing all of the more recent studies as well. But I think that, you know, we should not, because of a new study or a suite of studies that have come out, also not look at the body of evidence. And I think that, you know, we are, as I said, committed to making sure that we look at all the data, evaluate the quality of the science, and make our decisions based on what we feel, with input from a large number of stakeholders and subject matter experts, make the best decisions that we can make. So it sounds like we need to come up and do some briefings with you on a couple of topics where your medical background may lead you to have some special expertise and interest.
Thank you very much, and thanks, Mr. Chairman.
Mr. Laurel.